Hi, everyone. Jonathon Leipsic here. I'm professor of radiology and chair of the Department of Radiology and a professor of cardiology at UBC. I'm privileged to be co-hosting this session and this dialogue as a guest editor for the upcoming JSCAI exploration in cardiac CT. I'm here today with Dr. Chamié. Daniel, maybe if you wouldn't mind introducing yourself.
Yeah, I'm an interventional cardiologist and director of intravascular imaging at Yale University.
Wonderful. Thank you for joining us. So it's a real privilege today. I've followed the work of and know our speakers today, our colleagues that will be sharing some of their thoughts on their work that will be coming out in the upcoming JSCAI special issue, the role of computed tomography in cardiovascular risk stratification, diagnosis, treatment, and prognosis. So today we're here to discuss three important papers. The first, non-invasive coronary physiological assessment derived from computed tomography. The second, can coronary calcium score predict coronary artery morphology in patients with obstructive coronary disease? And the third, utility of AI plaque quantification. Results of the decisions for treating coronary disease are changed in patients evaluated with quantitative plaque analysis, so a so-called DECODE study. Dr. Rinehart, you owe me one for the complexity of that title. We are joined with really esteemed panel of leaders. All have contributed tremendously in the field of cardiac CT, in prevention, in interventional cardiology. We have Professor Bon-Kwon Koo from Seoul National. We know Kwon's work has extensively transformed our understanding of atherosclerosis and physiology and risk. We have Dr. Rinehart, Sarah Rinehart, who's a cardiologist in Charleston. Sarah has been a thought leader in the field of atherosclerosis characterization on CT for well over a decade, and her work has been seminal in advancing our understanding in the space. We also have Dr. Bourantas, Christos, consultant cardiologist from Bart's Heart Center and professor of cardiology from Queen Mary University of London. Christos and his group are doing a tremendous amount of work looking at NIRS, IVUS, and also OCT and comparing plaque characterization with CT. And we already had the opportunity to hear from Dr. Chamié. So thank you all for joining, and let's kick it off with Professor Koo, non-invasive coronary physiological assessment derived from CT. Please tell us a little bit about your paper, Dr. Koo.
So thank you, Jonathan, and thanks for the invitation. So this paper's kind of review paper, we'd like to focus on the CT-derived physiological assessment. And you know very well that it's become quite popular to do a functional assessment with the CT scan, because that the CT, the beauty of its performances lies mainly on the excellent negative predictability. And to improve its performance, we need a functional test while doing the CT scan or the ad hoc analysis. So that in this review paper, we discuss some details about the CT perfusion images, but more focused on CT FFR. So we know that the functional assessment or CT-FFR can be derived from the CT images, which provide a very nice performance in defining the lesion-specific ischemia, and it's already commercially used in the world. And there has been so many studies which initially show that its diagnostic performance in comparison with the invasive measure FFR. And we also now have several outcome data, including 3-year outcome, 5-year outcome, and 10-year outcome data. And also recent meta-analysis from Dr. Nogard group show that the negative CT-FFR medical treatment was associated with the risk of hard endpoints, such as the risk of MI and death. So that I think that while using more CT-derived FFR, we can better discriminate the patient risk and select the appropriate treatment for the patient with the chronic stable coronary disease. And what is more important is a futuristic approach. So CT is a kind of one solution for all assessment, including lumen, plaque quantity and quality, and per vessel and local hemodynamic assessment. And we all know that now it can be performed quite easily with the AI-enabled QCPHA technology, and which can be helpful to define the lesion performance, not only from the viewpoint of the hemodynamics or the physiologic severity, but also incorporating the important metrics such as luminary narrowing, plaque quantity, quality, and contribution of each component of the plaque, etc., can be assessed to define the future risk of the such as heart endpoint, MI, death. So that having all said that, I think that the CT-based physiological assessment now, along with the quantified and qualified CT lumen and plaque assessment, can definitely improve our care for patient with the coronary artery disease and improve the patient outcome while providing the appropriate treatment based on the knowledge we derived from the CT scan. Thank you.
Thank you. That's fascinating. And maybe I could ask you, and I know Professor Koo, you recently in your group just published a 10-year outcome study from the original validation study that you referenced, Discover Flow. But I think what's most interesting, and Dr. Chamié as well, your thoughts, but your work really integrating the focality of the plaque morphology and the phenotype of the pressure loss, the translesional pressure loss. This to me is so fascinating because as an imager, I always wondered, why would physiology-guided revascularization reduce spontaneous MI? And I think you're really coming down to helping us understand that, right? It's not about diffuse plaque, but it's focal and focal physiology. Maybe you could share some thoughts on that. And Daniel, I'd love your thoughts on that as well.
Right. So if I can speak first. So I think that's a very important kind of paradigm shift because I'm an interventional cardiologist. My treatment is local. And we also know that the MI and sudden cardiac death is a kind of a local event. Mm-hmm. But as you know well, that the physiology, FFR, non-hypertonic pressure ratio, it's a per vessel index. So it's helpful because that the per vessel information can also include the local hemodynamics as well, because there's some correlation. But I think that when we compare the vulnerability, such as a luminal narrowing, plaque character, adverse plaque characteristic, et cetera, while talking about the future risk of death of MI, I think it's fair and it makes sense to compare local hemodynamics. So that's why we shift our focus from the per vessel FFR or the CT-FFR to the local hemodynamics. And we found that the local hemodynamics, such as delta FFR, FFR-CT, has a much higher correlation or association with the plaque vulnerability defined by the CT plaque quantity and quality analysis. And also, it's a kind of stronger predictor than the per vessel FFR for future risk of the ACS, such as unstable angina or MI.
Thank you.
And I agree. And I think that this information is actually complementary to the per vessel ischemia, right? So one thing doesn't cancel the other. So I think it's important to know on a per vessel analysis if there is ischemia, and then you jump into these more detailed per lesion or per segment analysis, and you understand which lesion are really contributing to the entire region ischemia. And as you said, as an interventional cardiologist, I'm always trying to identify which lesions could potentially be responsible for the patient's symptoms. And what this type of analysis with the delta FFR per lesion tells us now is an association with more vulnerable features, which if you're understanding and integrating that information together with the clinical information you have, that you're not going to stent that lesion, at least you know that those altered dynamics through that lesion are, aggregating more risk to the patient, so you can upscale the clinical preventative measures.
Yeah, thank you. Thank you both for that. I think it's really fascinating for me as an imager, and I'm sure Dr. Rinehart and Bourantas also, we look at total quantitative plaque that certainly will help us understand the patient at risk. And, Dr. Rinehart, with your work and, trying to prevent plaque progression, all of that. But if you're going to try to treat focally and you want to also reduce spontaneous MI, the point you just made, Kwan, is so important, Professor Koo. I mean, it's you don't have a global 3-vessel STEMI, right? You have a focal event. And And I think this combination of inflammation and mechanical forces and plaque morphology will continue to grow, I think, of great interest. And I really just commend you, Professor Koo, for your tremendous insight and contributions, not just through this review, but really through the last 2 decades of effort that you put into this space. So let's pivot now to you, Dr. Bourantas, Professor Bourantas. Such interesting work that you've been doing in this space as well. Is so many intravascular imaging tools. I can't even keep track, but please share with us. You have very interesting data that flies in the face of what I've assumed to be the case before, and I look forward to you sharing some of the insights from it.
Thank you very much for the introduction. I'm interventional cardiologist. So when I have seen the first CT images, I have to admit that I was not impressed. The image quality that you see with intravascular ultrasound, and especially with optical coherence tomography, is something extraordinary. I cannot compete with CT. Nevertheless, we cannot discard the value and the potential of non-invasive imaging in risk stratification and treatment planning. So in this study, what we're trying to do is to challenge computed tomography and explore the value of computed tomography in assessing plaque pathology detected by intravascular imaging. So what we have done, we have performed a prospective study, including patients with stable coronary disease that came to cath lab to have percutaneous coronary intervention. The patient before percutaneous coronary intervention had 3-vessel computed tomography imaging, and then admitted to the cath lab and have 3-vessel near-infrared spectroscopy intravascular ultrasound image. And we map plaque composition and plaque characteristics from intravascular imaging on CT, and we compare CT with intravascular imaging. In this specific study, we evaluated the calcium score and assessed the efficacy of the calcium score to identify plaque morphology and plaque composition. Our results do not support the value of calcium score. We found that patients with low, intermediate, and high calcium score had similar plaque burden, and there was no difference in plaque composition apart from the calcific burden that was increased, of course, in patients with increased calcium score. The lipid component was similar in the 3 groups. Moreover, when we're trying to examine the value of calcium score and detecting vulnerable plaques identified by near-infrared spectroscopy IVUS, which is an FDA modality for stratifying cardiovascular risk and identify vulnerable lesions, we found that the calcium score was not able to find the patients that had vulnerable lesions detected on NIAS IVUS. It was defined as lesions with a small lumen area, less than 4 millimeters square, plaque burden more than 70%, and increased lipid core burden index measured by near-infrared spectroscopy. Interestingly, 1 in 3 patients that had a vulnerable plaque detected by near-infrared spectroscopy has 0 calcium score, suggesting that this modality is not accurate to stratify cardiovascular risk and guide therapy in vulnerable populations that are likely to have obstructive coronary disease.
That's really fascinating and so thoughtfully presented. I mean, Daniel, any questions from you or Professor Koo also as an interventionalist? Obviously, I'd love your thoughts too, Dr. Rinehart, but Daniel, did you have a question right now?
Yeah, no, I'd like to congratulate for this amazing work. And as an interventional cardiologist doing a lot of intravascular imaging, I know how complex it is to, integrate all those modalities and co-register and superimpose the metrics to come up with this very detailed analysis, which kind of confirms something that we always had in mind, right? So we see that those so-called vulnerable plaques are non-calcified plaques. So it was very interesting, the overlay Christos presents of the calcium index burden on top of the lipid core burden index. And this is the number to me that was the most striking as you presented. 1/3 of the lesions that are considered vulnerable with the 3 most important metrics have 0 calcium burden. So this changed the game, I think, in the way you stratify patients. So I just wanted to congratulate for the results.
I must ask, though, first of all, absolutely congratulations and very interesting work. I must ask Dr. Rinehart as well. I mean, what I was really fascinated by this work because I must say, no one thinks, I don't think I'm doing a calcium score, of course, to assess plaque vulnerability, but I am surprised. I mean, we know in those without any calcium, there's still a chance of certainly atherosclerosis, depends on the age of the patient, and even 4 to 6% stenotic range. But the frequency in which there was absolutely no evidence of calcification on the CT, and then the disproportionate amount of high-risk plaque was really sobering. And I think, Christos, you highlight a really important point. It's the population that is being studied, right? I mean, we have colleagues of Dr. Rinehart and mine, Professor Nasir, very thoughtful, talks about the power of zero, even in a symptomatic population. But this highlights that it's got to be in the right population. If it's a high-risk population, it's clearly not adequate. I don't know, Sarah, did you have any thoughts about this work?
Yeah, I think so. I think it highlights, again, when we talk about our paper with a plaque, some of what we see. Like, I think if you're in a very healthy population, like in California, who are very active, very healthy, the power of a zero score can be very impactful. If you're in West Virginia, where heart disease is almost #1 in the nation, I don't know how much I rely on that at all. I just read a coronary CT who had 2 or 3 vessels severe disease with a calcium score of 0. And it was fascinating because you're just like, it's so impactful. And we'll talk about our study, but I don't think it highlights, and I think we're underestimating the burden. And when we're talking about plaque progression over time, we always said, well, we can look at the calcium score, but what we know is if the calcium score progresses, it could progress because of stabilization of plaque versus is it just more disease? We don't know that answer without looking at that non-calcified plaque. So to really differentiate, is it stabilizing or are they a rapid progressor because of development of more plaque? It just shows the limitations of the calcium score alone, I think.
Well said. Yeah, well, Dr. Bourantas, thank you for that excellent work, and it's really fascinating and really humbling, and speaks also to the importance, as you say, of the complementary role. As I always mention, even when I present on CT for plaque analysis, we don't have anywhere near the spatial or temporal resolution or tissue characterization, obviously, of intravascular imaging. But I think what we need to do as we're seeing from Professor Koo's work and then now Dr. Rinehart's, to really, I think, try to explore, the non-invasive opportunity to at least enrich some of the studies and understand who those are. And I'd love your thoughts, Dr. Bourantas, Professor Bourantas, on Sarah's work that she'll share with us now called DECODE.
So I think this is an exciting study because, plaque analysis on coronary CT is now becoming clinically feasible because of all of the advances in artificial intelligence. And the question, though, was, we know the value of looking at the plaque analysis. We know that plaque burden is associated with events, but we really haven't looked in a strategic way as to, are we going to change medical therapy based on these plaque volumes? Are we going to intensify therapy? So I'm the preventionist, the lipid clinic runner, manager in the room, not the interventional cardiologist. So I'm looking at how can we transform? And what we know today is we're not doing a good job at LDL lowering. What we do know from cardiac CT is that we're improving outcomes from the standard of care. But how can we take and leverage the plaque that we're seeing on CT to really take it to the next level where we can drive LDLs lower by giving people concrete methodology? So this is just a thought-provoking study, I think, where we had 3 level 3 CT readers and we were given a CT report initially. And we were given different stages of therapy based off the Freeman paper. And just so you know, stage 2 is aspirin and high-intensity statin. So most of these patients had coronary artery disease. So that's why you see most of this with stage 2 therapy. We had a basic clinical scenario looking at their labs. Most of these patients, we assume, were on a moderate intensity statin to begin with. So we chose a staging based on the CT report. And then we looked at the plaque analysis where we saw the total plaque volume, but we were also able to see the coronary CT images. And then we said, well, would our management strategy change? Would we intensify our therapy based off of these plaque volumes as well as the images on CT? And I think we were all shocked by the results because what we found is that the reports weren't actually reflecting what we really saw. I think is one thing. And secondly, when we looked at the images and when we looked and reviewed the plaque analysis, there was so much more non-calcified plaque than even what we could visually see or what was commented on the report. So we actually intensified therapy of these patients 2/3 of the time. And similar to some of the other findings on the calcium score, what we found is the calcium score of 0, 50% of those patients were reclassified to a higher stratum of medical therapy, even compared to what we started with a report alone. So I think this is thought-provoking, and as you can see, we're advancing it. We're going to do plaque registries and different things to really take this to a higher level where we can say, what LDL lowering should we use? What LDL threshold should we use for each plaque strata, whether it's stage 1, 2, 3, 4, based on how extensive the disease? Because plaque is what we know is going to tell us what is going to happen 5 or 10 years down the road. It's not the risk factors. We know risk factors are poor. Plaque is the really true transformative thing where we can base our therapy upon. So I think that's what is exciting about this study, and I think it's just the first of many studies in the future.
Thank you. That was a great overview. I think you highlight where we've come. And, one of the key papers for me as an imager, it came from Freibeck and Thornberry in 1991. They proposed a 6-stage hierarchical cascade of evidence required to integrate a test into our clinical practice. And I think what you've highlighted here is we know that AI or machine learned algorithms for plaque quantification are feasible and they're reproducible. We have some evidence that they're reasonably accurate and concordant with IVUS, at least with some tools, to Professor Bourantas's point. But we then need to know how will it impact our decision making? And I think what you've highlighted beautifully here is that it may modify decision-making in a large number of cases. The question, though, Dr. Rinehart, is, are those modifications appropriate? I think that there lies the challenge. So what study would you do next to try to prove that?
So I think we have to teach people how to use the algorithms, and I think we need to know event thresholds for each plaque volume so we can really identify more accurately. So now that we've proven that it's accurate, is what volume thresholds are really associated with the risk. I think we have a few studies out there that give us an idea. For instance, from Scott Hart, we know that greater than 4% low attenuation plaque is a significant risk factor for future MIs. Again, there's a plaque threshold, volume threshold, or total plaque burden of greater than 250 or 238, which is associated with higher risk. But I think understanding those strata with larger volumes is very critical. But again, we have to be able to set treatment strategies and goals based on those, and then see if they improve outcomes. We have to prove that the outcomes and the changes that we make are effective. But I think it's really gathering that registry information, but it's teaching us how we should be doing a better job overall, because we know from different plaque registries, even people who have been stents, the Santorini study, the Gould registry, even people who have been revascularized, we're not getting them to goal. And this is a way to work in a non-invasive manner and potentially educate people. But I think there's so much education that has to be done, but we have to prove those are effective treatment strategies with outcome studies.
So can I also add to this, the fact, one thing that struck me a little bit was that most of the time patients were upscaled in intensity of treatment, right? Very rarely, or I don't remember if there is any number showing that you downgraded the intensity of prevention or treatment. Is this something that worries the field now, that you see more and then you tend to overreact? And another question, if I may, is that surprisingly, there was not much change on the indication for FFR-CT. And I always had this impression that, again, these are complementary information, and I'd love to hear Dr. Koo as well on this matter. We're looking at stenosis, we're looking at the plaque burden, but we don't know exactly what is the functional significance of those. So I was expecting that the more plaque you see, you can see the vulnerable components of that, but I also would like to see, what is the functional significance of those? But these information complement each other.
Well, I think the data is out there much more consistently for the FFR. When is it appropriate to send? And it's actually more reflective in the reports, I think. So we know for most moderate stenosis. So if it was clearly a mild stenosis proximal segment, or there was a comment of a high-risk plaque, we were much more consistent up front with what we would do, because there's clear set guidelines that we're following. And all of us are very good at that. So I think that just shows the proof of once you establish the evidence, we're much more consistent and compliant with it. That's why I think you didn't see much change. The interesting thing that I think for looking at the plaque volume, like when I'm reading FFR-CT, for instance, I look at if something is borderline in that gray zone but has a high-risk plaque characteristic, I'm more likely to recommend to the cath lab rather than just titrate medical therapy. If there's a delta FFR-CT, but maybe it doesn't reach that less than 0.8, I take those plaque characteristics to inform the interventionalist saying, this is one that needs watched. You may be able to medically treat, but I would monitor them very closely with a low threshold to send them if they have persistent symptoms. But for this study, we're looking at the total plaque burden, not necessarily that lesion level that the interventionists are looking at. But I think both are very critical when you're looking at the plaque and the FFR and deciding who needs to go and who doesn't. And I think once we put all of the pieces together and have an interactive platform with plaque and FFR, you're going to see that transform what we do.
Such a great answer. It's such an exciting space. I think what we're seeing is also, to your point, Dr. Rinehart, is there's the baseline therapy. And I think your comment, as we learned also from Professor Bourantas's work, that, calcium progression is obviously not necessarily adequate to understand treatment response, because it can outstrip the rate of overall plaque progression, or it could lag. And obviously the implications are different. So, global plaque assessment to assess medical therapy and efficacy of medical therapy, and the focal plaque features and the focal translesional pressure loss, perhaps to support, albeit, understanding that invasive imaging is going to provide a lot of insights that we don't have, but at least inform potential need for mechanical intervention. So I'll just open it up. Christos, Bon-Kwon, Daniel, do you have any closing comments? First of all, thank you all for the excellent discussion.
If I may add a minor comment, but is that today we are talking about a lot about of the CT derived plaque quantity, quality, lumen, and hemodynamic assessment. So previously, it was simple because ischemia directed or ischemia guided approach, FFR-CT positive or FFR positive revascularization. That's all. But now we are having far more information than that. So I think it's time for us to sit back and think about all the contributors. So as an interventional cardiologist, the question for me is that if I have a vulnerable plaque on CT scan today, what will I do? Will I send the patient to the cath lab or just do a medical treatment? Or as Sarah elegantly demonstrated that should I intensify statin treatment? For that, I think we have to solve two problems. One is time-dependent probability. Just saying this is high risk may not be enough. If we can say that the risk of this patient's of the ACS reach a certain probability in 1 year, 2 year, 3 year, I think that's very important. If it is 1 year, I will definitely send the patient to the cath lab to do a PCI. But 3 years, I'll intensify the medical treatment and we'll do a follow-up CT scan 2 years later. And the second element is that which component is a key contributor for this patient's event. For example, if this is heavily calcified burden plaque, and that's for the revascularization. But if it's a highly vulnerable plaque, which can be reversible, such as a zero calcium score on that plaque, which means that if I make the LDL less than 30, plaque will be reversed in 2 or 3 years. So that those two components, which will be a key contributor to the event, among all the too much information we have from the CT scan and the time-dependent event risk, if we have that, I think we can provide a very sophisticated and lesion risk level approach to the patients. But we definitely need more data.
Christos, last comments to you.
Yeah, adding to this, I think that now CT has matured. In the early stage, you need the believers like you that put the energy, push the field forward, support the technology to get better. Photo counting CT now is going to be to change the game. The image resolution will become much better. Now I think it's the time to focus on the plaque. In the early stages of CT, the focus was the lumen, and we know that you cannot assess vulnerability by only measuring the severity of stenosis. You need to see at the plaque position. And now CT has become good enough to be able to provide information about plaque position. Having matched 23,000 near SIVs with CT frames, frame by frame, I'm not sure that we are ready yet. And we need to pay attention to the detail. You need some deniers, not only believers, you need some deniers now and again. And we need to focus on the best image reconstruction protocol. We need to focus on things that we did not focus before, the effect of the scanner. We need AI algorithms that will apply to all the scanners, but we need also to take into account that the different scanners have different properties. The reconstruction methodology used may also be important. All these kind of details is the time now that we start looking at without, however, discarding the value for CT and in parallel focusing on large databases that will provide incremental information about its role in risk stratification. And this is something unique that we are able to study for the first time, plaque position in low-risk patients.
Great closing comments. I think it's wonderful to see. That's what's great about this JSCAI initiative and broadly, but bringing interventionalists and imagers and imaging interventionalists all together. And it's wonderful to hear an interventionalist really also drive home that important point. You know, scan parameters, two potential reconstruction algorithms. All of these things are important. So I want to thank the team at JSCAI. I want to thank Dr. Chamié as well for joining me in helping moderate the session, and to all of you for bringing forward such interesting science and sharing such insightful thoughts. Thank you again.